This is the appliance that I'm using in those end-on, more than end-on Class 2 patients, especially growing patients that need, that want aligner treatment. It's very efficient. The movement of this appliance, when you bond it to the molar and the cuspid, is to rotate the molar back. There's a ball and socket joint right there. It rotates the molar back and drives those teeth distally as it does that. The key to it is this angulation that you see here. Most appliances, as they distalize teeth, seem to tip them an inordinate amount, so that immediately when you go into fixed appliances or aligners, if you had to immediately upright that root, that's going to burn a lot of that anchorage and distalization that you developed. What I started doing is taking pans of all the, and cephs of all the patients the day we took them out of this appliance to look at where the cuspid root was to determine how much distal tipping are we getting back. And amazingly, this is about what we get. It drives those teeth back and maintains the angulation of those roots. So to me, that makes it an ideal appliance for Invisalign, because if Invisalign had the aligners, had to upright the root, very little crown movement, a lot of root movement, very difficult movement for aligners, the predictability would be low. In this particular instance, the root is being driven back, so there's none of that. I mean, it's just basically Class 1 alignment, closing some anterior spacing. So let me give you a couple of examples. Here's the amount of molar rotation you get. So yes, you do get some molar rotation. That's one of our keys to Class 2 correction. You certainly can get distalization in a very short period of time. So from an efficiency standpoint, it works very well. The cuspid control, again, the major question, what does it do to our cuspid? Well, I looked at all my photographs and I tried to pick out which one do I think looked the most out of control. Which one do I think would be the worst example of what you would get in cuspid tipping? And this was the winner. And there's what the pan looks like. And what I'll tell you is I see that consistently time after time after time is I don't see a space developing where the root's going forward, and they consistently hold the distalization once they're there. So the cuspid tipping is not there. Again, an ideal appliance to move into aligners with. So many of the things that you get from wearing this appliance are very beneficial changes when you wear them in terms of going into aligners. So we know we're going to get some mandibular incisor proclination. You would expect that. Again, not a harmful thing for aligners. That would be okay. Mandibular molar extrusion. Probably a good thing, because one of the hardest things to do with Invisalign is level a lower curvus B on a Class 2 patient, because you need to extrude the molars a little bit to level a curvus B, and you don't do that. But if you do that ahead of time by wearing these elastics, that's okay. The maxillary cuspid extrusion can or cannot be beneficial, but it's certainly not a problem, because one of the things aligners does very easily is intrude teeth. You know, it's one of the very predictable movements. So if you get some extrusion, it doesn't hurt at all. The maxillary buccal segment distalization is what we're trying to affect with this appliance. And then, of course, the one unwanted change would be mandibular plane changes because of your molar extrusion. So that tells me that this probably should be limited to your low mandibular plane angles or your normal mandibular plane angles. Certainly not probably a high angle patient would you put these on. And trust me, I can tell you I have, you know, every once in a while you get caught up with how good something's working and you put it on patients you're not supposed to, and you get reminded very quickly that you don't distalize on high angle patients, especially with something like this. So many of the things work well with aligners. Here's an example of a low angle patient. Look at what it creates for you in terms of spacing. That would be great for aligners to capture those teeth. So that works well. You can get very nice finishes. Here's the thing. Deep bites, very hard for aligners to correct. You wear this appliance first, deep bite gets resolved to a normal overbite. Problem solved for aligners. So again, one of the things that aligners has difficulty with, this appliance corrects right off the bat. So here's a patient that I did, 16-year-old girl, comes into the practice. I'm going to certainly tell you that there are many ways to correct this Class 2. She wants Invisalign. I'm going to tell you that a number of people would probably just start her with Invisalign and wear Class 2 elastics. I'm not comfortable that I'm going to try to routinely correct class 2s by having the patients wear aligners and elastics concurrently throughout treatment. I'd rather get that treated first. So we do the Carriere Distalizer. Distalize both sides, this side to a super class 1, this side to class 1. Takes 3 visits, 3 months of wearing elastics to do that. Then we go to Invisalign from this point. Now, instead of the class 2 being the biggest problem to correct, probably that lateral is the biggest problem to correct. There's the ClinCheck, simultaneous movement of teeth, 30 stages, no IPR. Here we are at the end of aligner 30. Do a case refinement, and I do a case refinement on about 99% of all cases. Patients, and this is the reason, we can correct little things, vertical discrepancies in case refinement. We can get the marginal ridges lined up. Those are the kind of things that you can do in a case refinement. So here's where we are at the end. And again, I will tell you that, this is pretty much my routine for these types of patients. Now, I fix the hardest problem first with the Distalizer, and then I go into Invisalign for class 1 crowded. Talking about efficiency, this is the efficiency you can gain by using an appliance like this. So this is the top slides are the original malocclusion. Look at the overbite. Look at the class 2 that needs to be corrected. You wear the Distalizer for 3 to 4 months, and you get the overbite corrected to class 1. Now we're where Invisalign can take over. 12 aligners, upper and lower. And then we do a case refinement, which was 9 aligners, and I wore those 1 week at a time. And there's our finished case. There's the finished pan. Take a closer look there. But here's the efficiency that you get by doing this. 5 visits, 4 visits, 2 visits. Those are the 3 distinct phases of our treatment. I think this is the kind of efficiency that would work very well for our practices, what we're looking at in today's world. So the day that the patient comes in, having finished wearing their Distalizer, we remove all the appliances, take PVS impressions, photos to send off to Invisalign. We do an initial pour of the PVS impressions and deliver in-house made clear Essex type appliances for the patient to wear at night only. I have them wear them 8 hours a day. And I have them continue to do that until we come in and deliver the aligners. Now the lower doesn't seem to be as critical because there's really been very little movement, but that's why I have them doing 8 hours at night. They're giving them, sometimes if their patients are teenagers, we'll give them bleach during that period. Say, hey, I want you to bleach your teeth while we're waiting on the aligners, just a bonus. The only elastics worn were during the Distalizer phase, which again is the reason I really like the Distalizer. I default to that fairly early because the only elastics are worn for 3 months doing that. And the carrot you dangle in front of them when you do that is you don't get your aligners until you've corrected this to this. And I show them exactly what we're looking for. So they're very motivated early in treatment. They wear the elastics, and that's all the elastics they have to wear. Because at that point, it's class 1 crowded teeth, and you don't need to wear class 2 elastics on class 1 crowded teeth. How do you explain the difference in the total amount of, the cumulative amount of force worn to get the Distalizer teeth into position versus the cumulative amount of force applied to the aligners? I couldn't even begin to answer that, but I think there's some keys to why the Distalizer moves so quickly. And number one, we're discluding the teeth. So when I bond a Carriere Distalizer in, I often, not always, but often incorporate an arm on the lingual, extending on the lower lingual arch, onto the occlusal of the second molars that I bond in place so that we disclude the teeth. Whenever I have a distalizing appliance in, like the Distalizer, I will bond the bite open somewhere so that we're discluded. When you wear that force to the aligners, you're moving that force over all the entire arch, and the Distalizer, you're applying it directly to 2 teeth directly. I don't have an answer for that segmentalized debate. I know the benefits of it is that it works. I've seen many cases of aligners segmentally distalizing. It works, and you can distalize very well. What I don't like is the trade-off of very long treatment times. I don't think it's in our benefit to have very long treatment times with aligners. But the segmental with the Carriere Distalizer is a much better segment than what we're doing with aligners, because with the aligners, you're doing at most 2 molars initially, and then bicuspids, and then cuspids. With the Carriere Distalizer, you're getting a segment of cuspid all the way back to second molar to full step class 1. So I think it's a much more efficient appliance. I have not seen that. If anything, it's almost the opposite. If I see any variation in the arch form, it's that you have a center of rotation. Once the molar's rotated and you keep them wearing the appliance, it's almost like the center of rotation of that segment is somewhere in the premolar area, and you start to see a little bit of the molar go lingually. Now, the second molars, no. The second molars, I will see a step develop between the occlusal surfaces between the first and second molar. So we're tipping that segment. Hopefully in the next year, we've got 2 university studies going on consecutively treated patients in my practice with the Distalizer, and we can put some numbers to this so we can tell you exactly what it's doing in all planes of space. But the second molars are not driving buccally. First molars lingually a little bit maybe. As the appliance is bonded onto the teeth, the technicians are instructed that the most mesial portion of that bracket, they take a scaler and push that down into the tooth so you've fully activated it mesially so that as they're wearing the elastics, pulling it distally, it's got the maximum amount that it can turn. You can also adjust that arm that goes between the cuspid and the molar prior to bonding it so that you can make it either more obtuse and rounded, or you can make it flatter. So that would also have an effect on the amount of rotation you can get.
So do you take an impression beforehand and have a lab do that, or do you do that chairside?
That's done chairside, but they use the initial models. I'm still archaic. I actually take initial. I mount all my cases, so I have mounted models on all my cases, and the technicians know to pull out the mounted models, get the right Distalizer, adjust it, and bond it. I can honestly have to tell the truth, I don't bond those things on. That's a delegatable job. You train the staff what to do, how to do it, they'll do it very well every time. So the question was, the lower lingual arch, if 12-year molars are available, or if I should say if the occlusal surface of the 12-year molar is available, we extend that arm on the lingual arch, 036, back to the distal, vertically up, vertically over, rest on top of the second molar, and bond that occlusally, which has the effect of adding anchorage and opening the bite opening to get your class 2 correction. The recommended forces for that appliance in the literature are 3/16 6 ounce, which is a very heavy elastic. What I do is I start with 5/16 4 ounce, and for 6 weeks, and then when they come in the next 6 weeks, I go to 5/16 6 ounce. So I'm using lighter than what is recommended because, there's a pain tolerance for patients. You just don't need to jump on them and kill them at day 1. They need to know their teeth are moving, but I've found that, I think from other things in orthodontics, light forces move teeth very well. So if you disclude the bite, open it up, give them light forces, the teeth move. And with that, I say thank you very much.